Well, good morning, everyone. Welcome to our second grand rounds of the calendar year. Our topic this morning is dysfunctional or abnormal uterine bleeding in adolescents. And it's my privilege to introduce our two speakers this morning. Dr. Arian Hess is a pediatric and adolescent gynecologist. She is currently the senior fellow here at Phoenix Children's. She graduated from Universidad Autónoma de Guadalajara, a bilingual medical school, and completed residency in obstetrics and gynecology at the Medical College of Wisconsin. Her passions include educating parents and young women about their own bodies. Her related research interests include patient education. She validated the Reproductive Health Knowledge Index, known as RHKI for adolescent females 13 to 19, with intentions to use it in further research. She enjoys hiking, dancing, yoga, and traveling. She's joined today by Dr. Camille Imbo, who received her medical degree at the University of South Florida, Morsani College of Medicine in Tampa, Florida, with a select certification which focused on emotional intelligence and leadership skills. She completed her residency training in obstetrics and gynecology at the Florida Brandon, where she served as their first chief of education. She stayed in the Tampa Bay area working as a generalist OB-GYN for a year and then continued the next step in her goal to become a pediatric and adolescent gynecologist by joining the fellowship program here at Phoenix Children's Hospital. She is also currently pursuing an MPH in healthcare administration at the University of Arizona. Her passions in medicine include public health advocacy and education, especially for young women of color and LGBTQ populations. Outside of medicine, Dr. Imbo grew up in diverse environments and speaks 4 languages, English, French, Spanish, and Basa, and hopes to learn more. She enjoys writing and has published advocacy articles in Kevin ND, as well as fiction and poetry. And then her other hobbies include traveling the world with her fiance, painting, doing Peloton workouts, or listening to Taylor Swift with her 2 cats. So without further ado, Ariana and Camille, go ahead and take it away.
I'm Ariana, going to be helping present here on abnormal uterine bleeding. Just to be clear, this is the heavy bleeding that gets them here admitted with us.
And I'm Camille Imbo. So we have no disclosures. We make no money that we know of from this. So our objectives essentially are to help you recognize the most common etiologies of abnormal uterine bleeding and how to get a proper history and physical for abnormal uterine bleeding, specifically in adolescents. And then kind of focusing more on heavy vaginal bleeding, the workup, contraindications to estrogen, management of acute heavy bleeding, and then acute, interim, and long-term management, including different forms of birth control, and then make you a full-on expert on heavy bleeding that you don't need a gynecologist at all. Just kidding, won't happen. So first, to kind of give you a broad perspective, what are the most common etiologies of heavy bleeding in teenagers? And just so you know, we'll have a little bit of audience participation, so keep your eyes open. So this lovely graph here is kind of the hormonal pathway that we often go over with patients when we're describing what leads to them having a period and essentially not having a period. And so I often tell patients your brain communicates with your ovaries, and that releases hormones that then communicate with your uterus, and that decides how that buildup in the endometrium happens and therefore leads to a period. So the first thing that is abnormal that can happen is anovulatory bleeding. So if you miss an ovulation due to that inconsistent release of hormones from the hypothalamus, that leads to inadequate progesterone and therefore an unstable endometrium. It's very common that in the first few years post-menarche, a teenager doesn't have consistent ovulation. And so in the first 3 years, only 60 to 80% have a regular cycle. We often tell patients it can take about 6 to 8 years to have 100% regular cycle. For some people, that means they're skipping months at a time. For some, it means they're having too frequent periods. Usually the ones that we hear about are the ones having too frequent or heavy periods. The other most common etiology is bleeding disorder. A heavy period is often the first time that this will be diagnosed in a teenager. Von Willebrand is the most common, and so you'll see as we talk about workup, it's often something that we'll just go ahead and include at baseline. Although it's an uncommon disease in the general population, of those who require admission for heavy bleeding, 33% of them will be diagnosed with von Willebrand. So it's important to keep that high in your diagnosis. And it can overlap with other things. It can have anovulatory bleeding and have a bleeding disorder and have everything else. So other things to keep in the back of your mind that may not be as obvious are other hormonal disorders, infections, pregnancy, as we unfortunately all know that can happen a lot earlier than we hoped. So thyroid disease is something we look into. PCOS is not necessarily an acute issue, something to keep in the back of your mind, but I'd say that's something more to tell them, hey, you should potentially get worked up for this. There's nothing that necessarily inpatient would need to be done. PID can cause bleeding, and then of course a miscarriage, but at that point, that's when you're in the wrong hospital. So the other things to think about is that we're focusing on teenagers. So if you maybe think back to med school or just your general knowledge, you may think of other issues that cause abnormal bleeding in an adult woman, such as structural problems like fibroids and polyps, but that is extremely uncommon in our population. Specifically, this great study from 2017 showed an ER had 156 patients with abnormal uterine, children's ER with abnormal uterine bleeding. And out of all the ultrasounds that they did, only 2 had a structural abnormality, but even then that didn't change the management. So just kind of keep that in mind when you're doing your workup. And then the other part is anything related to malignancy. Sometimes, unfortunately, radiology has to list all of the things that they see and all the things that it could be. And so they list cancer and then the family freaks out. There's a 0.0002% that a patient under 20 has endometrial cancer. So if you somehow diagnose that, get a lottery ticket, because that's not it. So, case presentation.
So today we weaved a case that we recently saw here actually at Phoenix Children's. We'll kind of be asking for your guys' feedback, what we do as we go along the way. So AS, she is a 14-year-old who presents to the ER with heavy prolonged period. What should we find out first? When her cycle started, yeah. Did you mean this one or did you mean?
No, like when she had her first period.
Menarche, yeah, when she had her first period, perfect. What else? Duration of the cycle. How many pads she's going through on a typical day, yeah. These are all good answers.
Awesome. You'll know everything already. You don't need this lecture. Bye. So yes, honestly, if you can get every detail of the menstrual history, that is like 90% of what we need when you're calling the gynecologist. So going kind of in order, menarche, as you said, when they started their period, and so that you're aware of normal, around 12.4 is the average age. Frequency, so we tell them, especially in teenagers, this is a little bit different than adult women, normal can range from 21 to 45 days. To be specific, that means either they're always around 21 days or always around 45 days. Skipping around back and forth is also abnormal. Something when asking a patient about frequency is checking that they're either tracking it, because you'll have patients say, oh yeah, my periods come all the time, or I get it multiple times in a month. But then I explained 21 days can fall twice in 1 month, and that is completely normal. Or you have some patients saying, oh, they're irregular. And when you ask them why, they're like, they don't come on the first Monday of each month all the time. So no one's does. So oftentimes you'll have to get more detail than you think. Duration, we tell them less than 7 days is considered normal. Again, a lot of teens will compare, or mothers will compare their own periods to their teens and decide that something is abnormal based on that. So if theirs last 2 days and then their kids last 5, they'll think it's prolonged, but less than 7 is normal. Quantity, as someone mentioned, is honestly, especially for if a patient's presenting to the ER for heavy bleeding, the most important question. So 3 to 6 pads a day is normal, but specifically with how full it is. So if you just ask how heavy is your bleeding, everyone will say super heavy, or I change my pads every 10 minutes, right? But are you changing your pads just because you don't like having the pad on? Or are you changing just every time you go to the bathroom? When we say full, are we saying, the entire thing is completely soaking through? Or so really, again, as much detail so you can actually paint a picture. And then pain is also kind of just an aspect of their menses in general, not necessarily what will contribute to heavy bleeding, but often goes hand in hand and can be helpful to know when differentiating, is it just related to their periods or is there something more serious going on? And of course, is she bleeding right now? Again, a lot of this is focusing from an ER perspective, but as you know, people will come to the ER for something that happened last week, and there's nothing we can do about that if you're no longer bleeding, so it's more about stabilizing them at that point, but it is no longer an issue with their periods because they're not on their period. And their last menstrual period, or LMP, as you'll sometimes see us write, specifically knowing when this started.
So back to our patient here, AS. Her menarche was at age 12. Her periods come every 1 to 2 months. Her periods usually last 3 to 5 days, but today she says she's been bleeding for 2 weeks now and she is still bleeding today. The past 3 days, she has changed her pads. They're completely full every 30 minutes. And then overnight, she's changing 4 times to avoid overflowing. She's been bleeding for her clothes during the day. She has seen quarter-sized clots, and her cramps are mild. They resolve with Midol. So what else should we find out for her? Yes, her sexual history for sure.
Family history, other people who have similar
Bleeding disorder, questions, family history. Yeah, so easy bruising, bleeding, kind of those bleeding disorder workup questions. And what do you want to know about what you need to do right now? So what exactly? Signs and symptoms of anemia. Yeah, perfect.
So yes, a little bit more history. This is where you just are absolutely stellar of knowing, does she have any signs of anemia, fatigue, dizziness, palpitations, shortness of breath, signs of bleeding disorder. And some of these, like easy bruising, I'll have patients say yes, but then they're a volleyball player and aren't covered in bruises. So again, really clarifying prolonged bleeding with cuts, nosebleeds, and nosebleeds even in childhood that may have resolved now. Sexual activity, as was mentioned, because then that leads to you of making sure there's not an STD or that they're not pregnant or having just been pregnant, delivered a week ago, and this is not their period. Medication history is another actually really, really important one and really common one of, did they just start or stop birth control? Because I always tell patients it can take a couple months for your body to get used to a switch in hormones. So that could just be a completely normal side effect. Or did they just start blood thinners, which will obviously change the quantity of their periods. Medical history, as was mentioned, the things that are related to our etiologies like bleeding disorders, thyroid issues, and then also things like estrogen contraindications, which we'll go into a little bit with more details. And then family history is helpful as well, actually, in how it contributes to the estrogen contraindications, but sometimes also if, mom had a very clear history of why she has abnormal periods, that could help direct you a little bit. If you don't remember anything that we just said in the last few slides, ACOG actually also has a great screening tool that you can pull up on the app. The questions kind of focus the first few on deciding whether you should be concerned for a bleeding disorder. The ones after that, 4 through 7, are kind of help guide you on how concerned you should be for anemia. And then question 8 is specifically about pregnancy. So it's something nice, if as you're going through it, you kind of blank and you're like, what question should I ask? This is a good place to start.
So back to AS, she reports some lightheadedness, occasional palpitations, easy bruising. She denies shortness of breath, loss of consciousness, nosebleeds, or prolonged bleeding with cuts. She denies any significant past medical, surgical history, unremarkable family history. for clotting disorders, strokes, MIs, that kind of thing. She is sexually active and she denies any history of STDs. So what would we expect to find on exam, or what kind of things are you going to be looking for on exam? Her vitals. Yeah, orthostatic vitals, heart rate, seizures, tachycardic. What else? Pallor, yeah, great. What other things based on the etiologies we have would you see on exam? Yeah, bruises, bleeding gums. Sorry, say that a little louder. Yeah, because you spiral, just as well looking at their eyes too. Sure, we didn't even put that one down, but.
Yes, so you got an amazing history, but you still have to touch the patient. So vital signs always going to be your number one thing, right? That changes everything. Are we having a casual conversation? Are you telling me to rush for anything? So tachycardia, blood pressure, things like that. But then, you know, a lot of you mentioned great things that you can see 6 feet away from the patient, but also physically examining thyroid can, you know, yes, you're going to check for thyroid, but that can be a good starting point for guidance if that to know how concerning that might be. Abdomen, to see just how much pain they're in, right? Because menstrual cramping shouldn't be something where you have an acute abdomen, so that would increase your worry about completely different etiologies or if there's a mass. And then pelvic exams. So in the teen population, a pelvic exam does not necessarily mean that you need to insert anything. So not a speculum exam. And I know comfort levels are different. People are often thinking, well, if I do one and then the gynecologist does one as well, that's too much for the patient. But when we're talking about heavy bleeding, if someone is truly heavy bleeding, if you just look in their underwear, look at their pad, open their legs, you know, even without any further touching than that, you can tell, right? So someone who's bleeding heavily should probably be wearing a pad, and it's actually helpful to see if you see a pad there and however much bleeding there is on there, asking them, when did you last put this on? And that tells you a lot. Honestly, from when I get a call, that's usually my number one question from the exam of what's her bleeding looking like right now. And so again, as we had mentioned earlier, some people, like if you don't actually look and the patient reports to you, oh, it's full, they could be referring to that very first pad. So another way that we look at it as well is like how much white is left on your pad. Because when you look up, they talk about milliliters, but no one's measuring how much milliliters they bled. So just kind of a visual representation, or on tampons as well, of course. Another nice little trick, and then this is for both the emergency room or if they're inpatient, giving them a new pad, and then in the ER while you're doing your workup, which usually takes a few hours, or if you're inpatient and you're gonna do something else real quick, like round, once you come back to them, you can have a good representation of, okay, it's been 2 hours since you wore this specific pad, now we can see how it looks. Yeah, not to say that our patients are liars, but sometimes saying that they change every 10 minutes and then you check it 2 hours later, there's nothing on there, or there's, you know, it looks like the first pad, can help guide your exam. Well, we didn't actually go into this, but then kind of the next steps of labs. So of course, pregnancy tests again, because that will just fully differentiate and be a completely different other lecture in the hospital. But we talked about, you know, anovulatory bleeding is our most common etiology. So looking at their hormones, FSH and LH for that perspective, TSH to look for thyroid issues. Like I said, I briefly mentioned PCOS is also something that can cause these issues. But I wouldn't necessarily go into testing for testosterone and all of that, because that wouldn't change your acute management. And sometimes it's worrisome to hear from a non-specialist that, oh, you may have this diagnosis, but not hear a full explanation of it. So just let us handle that part. Bleeding disorder lab. So of course, a CBC and iron studies are a good starting point to just know, again, your level of worry and how stable or not they are. Coagulation studies would be kind of that follow-up next step. And then the von Willebrand levels, which include factor VIII assay and activity antigens and multimer, which we specifically bolded because sometimes, you know, they'll only order one thing that says the activity, but that doesn't give you the full picture because only one of those can be abnormal sometimes. You don't necessarily have to get that right away. That's something where you should use your clinical judgment, right? If you did your exam and there's no blood and she doesn't look, you know, tachycardic, pale, or any signs of anemia, the way the description is, yeah, I've been bleeding for a while, but it's just spotting, there's a little less concern for bleeding disorder there. So still, you know, think through it a little bit. And then the other very common thing that people bring up is imaging. So if you're doing an ultrasound, gynecological ultrasound, you're looking at the uterus and ovaries. So ovaries, the concerns we usually would see is a cyst or mass, but that wouldn't cause any sort of bleeding, right? There's no connection from the ovaries to the vagina, unless you're thinking of like an ectopic pregnancy. But again, that would have been resolved with when you did your pregnancy test. And then your uterus, you're looking at masses like fibroids and polyps, like we talked about earlier. So based on those types of findings that you would see on ultrasound, raise a hands, who would order a pelvic ultrasound on the patient that we've been describing so far? Yeah? Why? I didn't hear the last part, I'm sorry. Gotcha, okay, yeah, and I'm actually glad you answered because all right. Yeah, so that is a very common thing that people will order, and especially, you know, like in the adult world, that is something that is a part of your etiologies for abnormal bleeding. But in teenagers, if you recall a few slides back, you're in that 0.000% of them having a fibroid, polyp, endometrial cancer. So it's honestly unnecessary. And, you know, luckily we don't do transvaginals, but even the whole having to have a bladder full, the whole process, delaying even care because it takes a while to get an ultrasound. So it's actually not necessary at all, right? So back to our case.
So AS comes in, her temperature is normal, her heart rate's 95. Her blood pressure is also normal, but on the low side. Pertinent exam findings, she does have a mildly enlarged thyroid. Her hemoglobin is low at 6.4, as well as her hematocrit. Platelets are normal, pregnancy test is normal, her iron stores are all low. Her fibrinogen is normal, her thyroid TSH is elevated at 48. And then her APBT is slightly prolonged at 41. Otherwise, other things look normal and von Willebrand tests are good.
And specifically, we didn't bold it, but I wanted to highlight the part about the von Willebrand test pending. We'll talk about kind of what the next things you may want to do for this patient are. But with von Willebrand, remember I said using your clinical judgment of when you should order it or not. If you decide, like in this patient, that she's someone who you are concerned for bleeding disorder, you may be transfusing and treating and all the things we'll talk about, von Willebrand is a specific test that gets affected by transfusions and hormonal treatments. So it's something that has to be collected before we give any of that. And it's extremely common that I'm not sure what I've heard, all sorts of different reasons, either that it was drawn wrong, drawn in the wrong tube, or put in the order but not drawn yet, it becomes useless. So making sure that if you plan on doing it, that it's collected usually at the same time as you're typing screen, because that's not something you would have automatically gotten. So as that next step before you do anything else. So let's go into acute management. So first step is stabilize. Now, of course, skip if stable. So deciding whether she needs to be admitted or not. So being hemodynamically unstable or having symptomatic anemia with ongoing bleeding. Because of course, if it's just the anemia, you can just transfuse and that would take care of that. But if there's ongoing bleeding, that's something that we would need to manage further inpatient. And so for your stabilizing point of view, as we know, volume expansion through IV fluids, transfusion criteria wise, that's something else to kind of use your clinical judgment, because we know our teenagers can walk around with extremely low hemoglobins and be perfectly fine. So if we're in that borderline of 7, but she's not really bleeding, it's looking perfectly okay, that could be something that you can potentially follow up outpatient. And then when you start thinking about transfusions, we often just focus on the packed red blood cells, but remembering that there are other parts to whole blood, which we'll go into a little bit more details later. So once you've stabilized and you're thinking about bleeding management, it's important to screen for contraindications to estrogen, which you've done in your history. There's this nice little app, the USMEC, which guides you through once you hear their history of seeing whether those are contraindications to estrogen or not. But as a quick kind of overview, migraines with aura are a very common one that gets forgotten because teenagers have headaches left and right. So making sure that when they say they have a headache, specifying what kinds and if they have auras with it. And then the others, things like thrombophilia, active gallbladder disease, cardiomyopathy, or valvular disease, strokes. Hypertension is another one that gets brought up, but this is uncontrolled hypertension, right? So if she's in the ER or inpatient and extremely uncomfortable, and it looks like her blood pressure is elevated, you can always double check, hey, has this been a concern with your primary care doctor before? If not, then that's not necessarily a contraindication. Nephropathy, liver tumors, lupus, but specifically with antiphospholipid syndrome, vascular disease, thrombotic risk factors, and then personal history of DVT-Ps and MIs. So that's another common thing of the parents always like to list all the things that they have, and not about them, it's about the patient. That secondary history is not necessarily important unless it's something where they're like, no, this is genetic, we're all going to have this. Then you can kind of step back and think about it a little bit further. So once you've stabilized the patient, next step is stopping the bleeding. So acutely stopping the bleeding, the most common and preferred way is IV estrogen, as long as it's not contraindicated. And we do that with 25 milligrams IV continuously. So it says every 46, here we'll usually do every 6 hours. And this is really important. So especially like, let's say in the ER or even inpatient, it's not just a one-time order that'll stop the bleeding for those 6 hours, but then it'll come right on back if we don't have a next step planned already. And it works by stabilizing the endometrium, increasing clotting factors and plasminogen, and decreasing antithrombin 3 and protein S. Another option, if for whatever reason estrogen is not available or the family is like no hormones, tranexamic acid, which can be done PO. So this could be for one where they're not admitted maybe, and it's not insanely heavy bleeding, but you want to slow things down until they, for this specific period until they see us. So they can do that PO for up to 5 days, or even admitted, you can add 1 gram IV TID, and just something to note for your nurses that it's given slowly over 10 minutes, and that inhibits fibrinolysis. Both of these, the estrogen and tranexamic acid, increase clotting factors. So if estrogen is contraindicated, then TXA is also contraindicated. So your other options are progesterone only, and that can be done with either Provera, known as medroxyprogesterone. 10 milligrams is usually what we give, and that can be anywhere from daily to every 4 hours. Usually the acute version is when you're in that 4 to 6. Outpatient is when you're more to BID or daily. And this helps with endometrial thinning. But again, with all of these options, as soon as they're stopped, they're going to have bleeding. So it's important that if it's something that you're sending a patient home on, that you either make sure that they have an appointment scheduled before their prescription runs out, or that there's already a plan for what we're going to do long term. And of course, if they're not bleeding, none of this matters.
Use estrogen, but I've never had estrogen complicated.
Mhm.
Does it take longer to stop?
That's a good question. Yeah, so just to repeat the question for our online folks, the question was between IV estrogen and Provera, does it take longer if using a progesterone method for the bleeding to stop? So with IV estrogen, we usually say it takes about 24 hours if this is kind of your typical bleeding not related to other issues. With Provera, I'd say it could take a couple days more. It's hard to give you like a direct answer because everyone's very different, and it depends on what kind of bleeding we're talking. If it's that daily spotting kind of issue, that'll probably resolve a little bit faster than if it's someone hemorrhaging. But yeah, that's something to keep in mind of which option you chose and that it can take a little bit longer. Good question. Now, the other thing, we're gynecologists, so everyone always wants to send us to the OR, which we love to be in, but not necessarily with our teenagers. So when you're thinking, oh, should she go to the OR? What exactly are you saying that we should do? One option is intrauterine tamponade with a Foley. That's like literally holding pressure on, if someone was bleeding from their arm kind of situation. These pictures are kind of what that process looks like. Now, this uterus is basically an adult uterus that's pretty big, and you can see how large that balloon is. Our teenagers, basically, I usually tell people your uterus is the size of your fist, so it's a little bit smaller. And the other thing to consider is you have to feed that Foley through their Oz, right? So that's not something you can comfortably do at bedside. And it's not resolving anything, because again, it's just putting pressure. If we hadn't done everything else, she'll bleed right up, she'll still continue bleeding. The other thing that often gets brought up as well is, again, if people have been on L&D or worked with adults before, they think of DNCs or dilation and curettage, where we purposely go in and thin the endometrium. That's just a terrible thing to do on a teenager, so we will very quickly say no. So really, the short answer here is extremely unlikely that we would do surgical management. Our own attending was talking in all of her years of practice, she's placed a Foley balloon once on a patient. And we've had, the extremely unstable patients, the ECMO, the you name it, and it's just still not likely going to be the option. Because the other thing to think about is if you're starting to worry that our medications aren't working and you're like, oh, we need to go to surgery, that's probably because this patient is extremely unstable. Should we take an extremely unstable patient to the operating room? Correct. The answer was no. So yeah, so it really doesn't end up working out either way. Now, if you are still asleep because it's early in the morning and have missed everything that we've said, there's a beautiful clinical pathway done by the lovely Dr. Parks that is available to all of you. Now, the important thing to note is that this is for someone who is actively bleeding, because this talks about admitting them and then kind of what you see on your labs and what the next steps are. If they're not bleeding, this isn't it at all, right? So it doesn't matter what their hemoglobin is, what their blood pressure is, that is where you're just stabilizing them and focusing on that aspect. But if they are bleeding, the lovely yellow cloud in the top left tells you what the admission criteria should be. Right underneath, it lists those estrogen contraindications again, and then takes you through the whole pathway. So very helpful for you to kind of carry with you.
So remembering back to AS, what should we do for her? What do you guys want to do? We can go back. Is she on this pathway? Yes, she's on this pathway. So what do we have to decide if we're going to do? Yeah, are we going to transfuse or not? For sure. What else? What was that? Yeah, how are we going to stop her bleeding? IV estrogen, If she's getting those two things, where else is she going? What was that? The OR. The OR, yes. No. Where's she going? We're gonna admit her, right? And then remember, what was her other findings that we need to go ahead and address? Yes, and what was the other thing that was also elevated? Yeah, so what do we gotta do for that? Yeah, well, we consult endo, but you guys can start levothyroxine, okay? So exactly, admit her. We'll show you guys the heavy menstrual bleeding order set real quick here. Transfuse her because she has symptomatic anemia. We're gonna start the IV estrogen we talked about, and then we're gonna treat her hypothyroidism.
I like that you mentioned her, yes. Yeah. I think her T4 was slightly low. Yeah. Yeah. The question was about her thyroid, but yes, based on both her TSH and T4, she had hypothyroidism. Yes. But I also, like you mentioned, the PTT earlier, and we'll come back to that. That is something that should be kept in the back of your mind for this patient. But yes, so we told you all these things that you should order, and so you may be kind of scrambling to remember it all. But again, we have a lovely order set for you. We try to make it easy for everyone. So even if there's labs that you already had ordered, everything is pre-clicked. You don't have to unclick anything. The all scripts will always tell you, oh, this has already been ordered, and then it'll unorder it for you. But it's important that you leave it pre-clicked because it includes all of the labs that we want, specifically all the von Willebrand labs, so you don't forget any part of it. It includes IV estrogen, the 25 milligrams continuously, Q6 hours. And the other really important aspect that is often forgotten is include pad counts, right? Because while they're inpatient still, yes, you already looked at what their bleeding was like, but if we're going to start treating it, how do we know if the patient is responding? So making sure that those pads are weighed and we can have a numerical finding that we follow as the patient is inpatient. So this is something else to write down: heavy menstrual bleeding order set. Literally just type that and everything pops up for you beautifully. So something else to think about as you're doing all these things, of course, are your PRN needs. So estrogen can cause a lot of nausea. So having Zofran available, iron replacement, obviously, because with acute bleeding, most often you'll have low iron. So PO iron is the most common usually that we can go ahead and go for, but if for whatever reason patient can tolerate PO, or you're one of those borderline where you didn't transfuse them, but you want to start replenishing them a little bit faster, IV iron can also be used. And then of course with iron comes constipation, so taking care of that with Colis or Metalax.
Okay, so our patient was started on IV estrogen and her levothyroxine. However, she continued to bleed heavily over the next 3 days. So her blood loss in the first 24 hours was 1,600 cc's. Her hemoglobins ranged over the next several days from 6 down to 4, back to 7, back to 4. We put a reminder there for your labs. We see that prolonged APT again from the beginning. She gets 3 units of packed red blood cells. And then after 24 hours, we're like, gosh, she's still bleeding. 1,600 out, that's a lot. Let's add some stuff on here. So we gave her IM Depo-Provera. We started her on Provera 10 milligrams 3 times a day, and we started her on tranexamic acid. What else do you guys think she needs? Yeah. You guys are, yeah. Yeah, so he's talking about how we don't know her von Willebrand stuff yet, probably don't. But went along the path of like exhausting her clotting factors, right? That's exactly what's going on. So we see this in obstetrics a lot too, where we are, I'm not gonna say commonly, we don't want to have 600 cc's of bleeding, right? But that is something that we are very used to seeing on a regular basis. But here, this is in a non-pregnant teenager with heavy bleeding. Similar trauma principles apply in that sense because of the degree of bleeding. So she's exhausted her clotting factor. So she did need 2 units of FFP. And we consulted team.
So yes, so I was saying to keep her PTC in the back of your mind. And yes, you mentioned the von Willebrand, but that's why I highlighted oftentimes we get to a point where that just wasn't drawn and there's nothing we can do at that point, but you can still think about her coagulation. So we wanted to quickly hit fresh frozen plasma because when someone is bleeding, they're not just losing red blood cells. The first unit or 2, but at a certain point, you're just transfusing and it's coming out because there's no clotting factors to hold on to. So FFP is your coagulation factors, except for factor 5 and 7, it has von Willebrand factor in it. So if that happened to be a problem, you're taking care of it. And albumin. Indications for usage include DIC, which we often see in pregnant women, idiopathic TTP, major hemorrhage, which is usually defined as greater than 1,000 cc's in 24 hours, hemorrhagic disease of the newborn, which you all might have more experience with, and abnormal coagulations, so that's greater than 1.5 above normal. As far as how often or when you should start considering FFP, this is where, multiple studies kind of are all over the place in the OB world. We've learned sometimes like the 1-to-1, if someone is actively bleeding, as you give the blood cells, you also give FFP. And of course, in this setting, that may not work because 1 unit may be all they need. So we usually say, once you've hit 3 units of blood, that's when, okay, you should be incorporating FFP. Doesn't mean they need to go to the ICU. It just means you're replenishing all parts of their whole blood. So now we'll talk more about the long-term management.
So at this point, we're going to transition to an interim period, sort of here. We use long-term management options during this stage, but the general strategy or goal here is to suppress periods, suppress menstrual suppression is what we call it, until resolution of their anemia and their iron stores are depleted. So it's going to take on average about 3 months for informations. Okay, I think we're probably all familiar with iron repletion. We commonly use ferrous sulfate, 325 milligrams, but our goal really there is to get 65 milligrams of elemental iron. You guys are probably even just as much estrogen as us, as far as repleting it, the weight based, all that kind of stuff. But start repleting them. And then also, again, just a reminder to mitigate those side effects. As far as what I tell my patients and kind of counseling tips, so menstrual suppression is not perfect. They're going to call you if I have 1 little spot of blood, but it's not perfect. And stressing the importance of compliance is also important because, the way our bodies naturally trigger bleeding is by dropping the progesterone. If we have them on estrogen-containing progesterone options and they do not take them regularly and consistently, they're going to have bleeding because that's a similar situation. They're taking hormonal medication, they miss a dose, their progesterone levels drop and they get bleeding. Okay, so I tell them to anticipate some level of breakthrough bleeding because it's not going to be perfect. But our main goal over the next few months is to help stop that really heavy bleeding that's getting them admitted here to the ER with us in the hospital needing transfusions. Okay, and during this stage, what we're kind of also helping do is overlapping our inpatient management with our outpatient management, especially if we're using IV estrogen. If you're using IV estrogen and you haven't started your new plan yet, they're going to, have that rebound breakthrough bleeding. Okay, so we like to cross, when we're using IV estrogen, at least 1 dose of their long-term plan with a dose of that. Sometimes if IV estrogen is contraindicated, we started Provera, we're already kind of on their long-term, we could be very well on their long-term plan, and that's a common thing for us to leave it. So, but specifically when we're using that IV estrogen, our goal is to overlap. Okay. As far as those interim management, this next 3 months, common option we use is 30 microgram ethinyl estradiol pills with 2nd-generation progesterone. So that's your levonorgestrel and your norgestrel. Here at PCH, we have 1 pill on pharmacy, okay, in the inpatient pharmacy, also available, of course, outpatient pharmacy. And if you pull up that heavy menstrual bleeding disorder order set, it's actually one of the options in there. Okay, that's not one of the pre-clicked ones, but you can add that. If you are fortunate to be able to send the patient home. Pharmacy will tell you cannot crush the pills, but we can crush the pills. We need to, and you suspend them in water. Okay. And then as far as tapers go, you'll see us commonly do that. You'll see anything from 3 times a day to twice a day to once a day. Our general strategy is using it twice a day for 4 days and going down to once a day. But this is all in context. So, for example, our patient that we've been talking about this whole presentation, she was bleeding for 3 days. Okay, we're going to be more cautious and we're going to back it up and be like, we're going to give, her final plan 3 times a day, then back it down to 2 times a day and then 1 time a day. So it's kind of all context. The reason we're doing this is we're balancing side effects, ability to be compliant and actually control the bleeding. So that the estrogen is very emetic, giving it to them 3 times a day, they might not be very happy with that, but it's controlling their bleeding. So you find that balance of like twice a day seems to control that bleeding for most cases, anywhere from 2 to 4 days followed by daily. Okay, so that's kind of a clinical judgment thing. And if you're having trouble stopping the bleeding, for sure, please use a longer taper. Other options, so we've already talked about contraindications, of course, estrogen. So then we have our progesterone only options. So progesterone only options come in pills as well. There is some that are birth control and some that are not. So the mini pill is what is most commonly known as norethindrone, 0.35 milligrams. It comes as Arian, Camille, a whole bunch of girl names. Those are all going to be 3-week packs of the norethindrone. And then Heather, if you prescribe that, is actually going to be a 28 pill pack. Okay, so it's a 4-week pack, no placebo in that one, which can be useful in this particular setting, right? Where we're trying to stop their periods for 3 months. We also have a sling. It's a newer option, estrospironone. As far as tapers, we can do the same thing with the tapers here. Still using our clinical judgment to decide if we're gonna do 3 times a day, start at 3 times a day or twice a day, but we usually do the same thing, start around twice a day for 2 to 4 days, then daily. And then we have progesterone only non-contraceptive use. So Provera is not a birth control. It is just a progesterone, progesterone, okay? That's what we're using often acutely to stop bleeding, but it's also something they can go home on. We're using anywhere from 5 to 10, even up to 20 in adults if we need to. We can use in kids too, but commonly we're able to control it with 10, anywhere from once a day to 3 times a day. And then we also have agestin. It can be a little confusing because that's this norethindrone acetate. Okay, it is also not a birth control. It ranges from pill doses of 5. They're 5s, 10s, 15s. We can kind of titrate that as we need to too. Okay. Other interim management options are patches. So patches are combined options as well, like the pills. They have estrogen and progesterone. The way these work, we got Twerla, we got Dulane, which is the same as Bemi. We put them on, wear them an entire week. If we're gonna go the menstrual suppression route, like we're talking about in this interim period, what we're gonna do is wear the patches back to back to back. So there's gonna be no breaks, no time to allow for periods, okay? And then commonly we use double Provera as well. There's 2 ways to get double Provera. One is your traditional IM, that's 150 milligrams. It's gonna last in 3 months. And then subcutaneous is 104, but also will last 2 to 3 months. It's given every 10 to 15 weeks. If you search on Google, double Provera perpetual calendars, PDS, you will find this calendar here. On the left side column, you'll see the date that it's given in purple, followed by the due date range. And that's gonna be your 12 to 15 week range. Okay, so if you wanna give it every 10 weeks, because that's controlling their bleeding better, you kind of have to calculate that on yourself, but this is a good option. You can also use it to backtrack too. You know, they told you they got their depot January 1st. When are they going to need their next dose? Kind of already know if they're doing. Okay. And the double Provera is available in the emergency department, so you can send patients home on it if they don't need to be here. Get them 3 months down the road, certainly until they see us, and then we can also give it inpatient as well, as you saw with that other patient. And then doubling up, you'll see us do this too. We're combining a short acting and a long acting. General principles here is we are not combining 2 estrogen containing options. Okay, so you can use pills or patches. Combine estrogen pills or patches. You can also use progesterone only pills. And one of your longer term action options like Depo. It's usually what we're using in this acute phase. Talk about with IUDs and stuff like that too. That's the thing we do. But usually when they're going home, the long acting option we're combining with this Depo. Okay, and then you can combine with tranexamic acid as well. Just keep in mind, you know, if you're using an estrogen containing option, there is that fibrotic waste. You can do them together. Some girls with bleeding disorders need it together. That's fine. Some pharmacists don't really like that. It is a theoretical risk we're talking about with the tranexamic acid as far as, you know, clotting risk. But we generally apply that same, trying not to combine it with an estrogen containing option out of precaution. Okay, so back to our case here.
So after we gave her FFP, she stopped bleeding and we were able to discharge her home with a more stable hemoglobin of 10.3. As we discussed our options, Provera TID taper was used for 4 days. If you remember, that's something she had already been started on. So kind of just continued that and then tapered down to BID and then daily. We saw her 2 weeks later and she was not bleeding anymore. She only reported mild fatigue. Her point of care hemoglobin was 11.5. And as far as Dr. Hess was talking about for long-term management of her periods, she wanted to do Depo-Provera injections. So you can kind of see how there's that acute of what we're doing and then switching over with long-term. And so that for that, she'll be coming back every 3 months.
Oh, okay, we're almost out of time. I'll go through this part quickly, but also just note too, whenever you stop, that's whenever she stopped her Provera, you know, we may expect a little breakthrough bleeding, even though hopefully not, but she has a Depo on board, but hopefully not, okay? But you can get it. As far as long-term outpatient management, so this is like 3 months is over, her blood counts are restored, her iron levels are restored. What can we do now? We can continue the same thing if they like it, but we can also change the regimen and allow them to have periods. So this is kind of more of that talk. This is a list of combined birth control pills that have 20 micrograms of estrogen, many of our favorites here. You see Yaz on here. We'll commonly use that because it has other additional indications. PMDD, so mood fluctuations around periods, acne. It's also a 24/4 pill. What that means is you have 4 days of placebo and 24 days of active pills, which is nice. That means you can shorten their periods more effectively. Okay, we have common packs here like Western and Junel. These ones are nice because they come in 2 ways. They come with an iron placebo week at the end. That's going to be your FE pills. Or you can get a 3-week pill pack that doesn't have a placebo in it. So that's useful to use a continuous. If some people just don't want to take the placebo pills, they have that option. And then Blissovia is kind of like a variant of that in the sense that it's also the same ingredients as the Western and Junel, but it's like a 24/4 as well. So 24 active days for placebo days. And then Merced, it can be kind of nice for pain too. We see them respondable to that. The long-term options and also include 30 microgram pills. We have some of our favorite 30 microgram pills. Yasmin is the same ingredients as Yaz, but it's higher dose of ethanol estradiol. You see Cristal, low Drostrel, low overall. Those are the ones that we have inpatient. Those are actually all equivalent. Marlis is another good option for patients with heavy bleeding and pain, but we also see it's less androgenic than the low estrol, so they don't struggle with acne as a side effect as much. That Apri and Skice, a lot of times we'll use that. They have painful periods as well. And then the low estrogen Junel are pretty nice as well because they come in a 30 microgram pill pack, same situations, the iron and the not irons packs. And then Seasonal is like a 3-month extended cycle pack. So you can use those low estrogens to extend the cycle, or you can get them an extended cycle pack where you're suppressing their periods. Okay. It's 84 active pills followed by 7 placebo pills. We also have some chewable pills. We all get those patients that can't swallow pills, have special needs, those kind of things. So there are some chewable pills listed here just to kind of keep in mind all different estrogen doses, different progesterones as well. Some of them have iron. If they cannot have estrogen, again, we have the same progesterone only options. So progesterone only birth control pills, they're the same. Progesterone is the same. And then our non-contraceptive pills like Agestin and Provera, these can all be used to regulate or control bleeding. Long-term options still include the patches as well. You know, if they want to start allowing periods, what they do is they wear 3 patches in a row. Last week, and then patch every period. And then Depo-Provera is still something we can use long-term, and you can give it either way. Predominantly give it IM, but it can be given subcutaneous if needed. And then the other long-term options we have are the Nexplanon, which is a subdermal implant in the arm, lasts 3 years. I will say this is not our favorite option. It is an excellent birth control option. It's the most effective birth control option, but as far as managing bleeding, only about 20% of girls get amenorrhea with this. That means the other 80% have some level of bleeding. Okay, and sometimes that's like spotting here and there. But some girls get up to daily bleeding with this. So it's not our favorite when we're kind of trying to control somebody's bleeding. We often have to use additional medications, like when we were talking about doubling up, commonly Agestin and Provera, to further suppress bleeding if we're getting a lot of breakthrough bleeding. And it's not like double Provera where, you know, first shot, second shot, third shot, it gets better. We see that some girls have it every day, the whole 3 years we have it in. And then we also have hormonal IUDs. So we have the Mirena and Camille. The Camille is 5 years, a little bit smaller in size. Mirena is 8 years, a little bit larger in size. These are very good at suppressing bleeding. At 3 months, we say they reduce bleeding by 80%, and at 6 months, it's by 90%. So it almost takes 5 per period, oftentimes. Okay, so people are frequently very satisfied with that. Other than that, we just have our references here. Questions, concerns, thoughts?
We have 2 coming in the Q&A right here. In mid presentations, you might have answered them a little bit. First one is, what should we tell patients to expect in terms of bleeding once home when discharging after admission for estrogen?
Yeah, so yes, those counseling tips I was talking about. Menstrual suppression, which is our goal for the first 3 months after they leave the hospital, not perfect. They should anticipate, unfortunately, some level of bleeding. Okay. The most important thing is take your pills and take them on time. if you're using pills, whatever you're sticking to, do it on time. Reason being is if you stop that, you'll get that breakthrough bleeding. Okay, I always tell them our goal is, you know what it's like to have heavy bleeding now. You have been here with us, you have been admitted, you have seen what heavy bleeding is like. Our goal is to prevent that. Okay, so like bleeding, spotting, it may happen. Okay, and then also you can counsel them on the signs of symptoms of anemia, because that should be triggers to get something coming sooner.
Okay, second question, can you go over outpatient management using those OCPs to control the bleeding?
Outpatient management, OCPs to control bleeding. Okay, so you know how so essentially what we're doing here is you're cutting off the triage algorithm movement through, right? With acute bleeding, these patients need to be admitted. If they don't need to be admitted, what you're doing is you're starting at step 2. You are starting with the interim plan to get them suppressed for 3 months, right? Say like their hemoglobin's 9, they're spotting, bleeding a little bit, but they don't need to be admitted. So you're going to do all those things, or the options are all those things that we talked about for their interim bleeding. You can start pills, you can use a short taper. Any of the pills, birth control pills, Provera, and Agestin, or the progesterone-only birth control pills, depending on what's appropriate. You can give them a shot of Depo, and that one's interval. You can use the weekly patches. So essentially, you're kind of starting at this interim management phase to suppress their bleeding for 3 months to get them recovered, and then you kind of go on to your typical outpatient management.
One question just came in, and you pointed out that we don't need ultrasound for bleeding, but if there's pain or something else, do we have access to transvaginal ultrasound in sexually active teens, or is it completely unavailable at PCH?
We do. We do have one transvaginal probe. We don't use it very often, and the ultrasonographers, I understand, are not comfortable using it, so it does end up needing to be one of our more skilled favored radiologists. So this is not something we're doing in the emergency department. If we order one in our clinic, we send them to an outside facility like Smile or something like that, predominantly so that the ultrasonographers can actually use the probe. So practically speaking, not really, but yes, we have one.
Everything needs to be on a transabdominal. Even in patients who are a little bit larger, like you're still able to see it pretty well.
So Dr. Parks was saying, just so you know, everyone can hear, that we can see most of what we need to see on a transabdominal. So that's another reason, we need to do that.
You're trying to figure out if they're pregnant and get a gestational age, but you can see ovaries, you can see the uterine lining, you can assess for a fibroid or even a follow-up really well with transabdominal.
So the most common things we need to see with the transvaginal probe are very early pregnancies. Maybe if you're counting follicles during reproductive care, that kind of thing. But the degree of detail that we need is predominantly covered by the transabdominal. Just looking at the endometrial lining and the structure of the uterus and the structure of the ovaries. So. Well, if she got transfused 3 months, right? That's when we can repeat it. Oftentimes if they're getting IV estrogen, they're going home on some level of estrogen, and that could affect your repeat labs. And you should take that into consideration when you're going to repeat it. So, I think most of us would probably say you want their anemia resolved, okay? Because anytime they're still anemic, those things could be artificially elevated and acting like acute phase reactants, right? And give you false reassurance that they don't have a bleeding disorder. We talked about what the estrogen does, and it increases those clotting factors, including some of the von Willebrand things. So if you're going to be very technical about checking that, you're going to give them a break from estrogen for 3 months before you repeat it. But practically, we don't see that that's actually truly an option, right? We need to control their bleeding. That's more of a permanent priority. And especially in girls that end up going on to have diagnosed bleeding disorder, sometimes that's what there's no opportunity to take them off something. So you can interpret them in context. We know that 50 microgram pills and above that are the ones that predominantly are going to create that, artificial elevation. So the pills that we're using Oftentimes, we're just gonna leave them on the 30 microgram pills and repeat it at an appropriate time. And interpret it in context of being on estrogen. So if they were very high, you know, you're not worried about it. If they're that borderline low region, then, you know, maybe you're more suspicious, and that's when we send them to the hematologist.
So we're out of time, so thank you very much, and if anybody else has questions, feel free to come on up.